Welcome. We're glad you could join us. We are members of the Academy of Geriatric Emergency Medicine, AGEM. We're a great resource if you're interested in aging or you have that one difficult older adult patient in your ED. We may not be much help at that time, but just so you know that philosophically there are people who share your pain. We also do a lot of research in aging in aging and the care of older adults, and we're always looking for collaborators in whatever specialty areas you might have. So feel free to reach out to us. So we're here to give a talk about the older adult patient in the ED. This is someone that we all have seen at one point in time or other, and we just wanted to share with you our perspective. We're glad to see so many of you who are not part of AGEM, so we're delighted that this has garnered some wide interest. One of the things we believe in is the interdisciplinary approach. So today's talk is given by two emergency physicians and a bona fide board-certified geriatrician, Mike LaMantia, whom we're happy to have. So welcome. We have no disclosures at all. Probably won't have anytime soon. But, so I think this is something, I wouldn't call this a problem. This is a phenomenon that we're all dealing with. Our patients are getting older, and they're increasing in numbers. And 5 years ago, it was 40 million. Actually, now it's 50 million, and this will continue to grow. They make up about 1 in 5 visits, 20 million people, and they have a myriad of complaints. One of the challenges in trying to get a better handle of folks with agitation is that neither the chief complaint nor the final diagnosis usually reflects that. So when we try and look back at data, administrative data, ED-based data, to try and get a sense of what's the scope of this problem, it's always a challenge. So as best as we can tell, up to 11% have delirium. There's 2% that have this vague complaint of psychological symptoms. But a lot of them have some form of altered mentation, which we assume could be behavioral, could be delirious, or could be something else. So that's what my colleagues and I are here to talk to you about today. Yeah.
So the format for this is that we're going to go through with you myths, pitfalls, and pearls for you to take away for management of older adults who have agitation. And start off just with a few myths here. That the first one is that acute agitation in older adults is always due to delirium. The second one is that agitated older patients in the emergency department usually have a psychiatric problem. And we'll reflect here on a factuality, right? That behavioral problems are in fact very common in older adults, particularly those who are affected by dementia. When you take a look at community statistics, we see that 75% to 98%, depending on the sample that you look at, of community-dwelling older adults with dementia at one time or another during the course of their illness will have what are called behavioral problems. 16% to 23% of older adults develop psychotic symptoms, primarily related to advanced dementia. But yet, primary psychotic disorders are exceedingly rare in older adults, thought to make up less than 1%. So it is, don't be suspecting that somebody has a new onset schizophrenia. If they're 80 years old and they show up and they're responding to voices that they all of a sudden hear. Those primary psychiatric problems are very rare to see develop out of the blue in someone. Talk a little bit here about general pearls. Agitation is very common, but primary psychiatric disorders are not. You need to think a lot about the context of what's being reported to you. You need to get that story from the caregiver or the person who's able to provide you with information about what's going on with that behavior or that symptom that they're coming in to talk with you about. Is this new, or is this really just a continuation of old behavior? Right? Is this someone who has had problems with hearing voices before or seeing people? And this has already been looked at 2 years ago, but now all of a sudden a daughter has come in from Kansas City, right, and notices that this is going on, and decides to bring her into the emergency department. You also need to consider, you have to put on a little bit of your Sherlock Holmes hat and consider what's changed in the person's environment. Right? If you think about that people are reach sort of an equilibrium, what's changed? What was the thing that upset them and kept them from being nice and stable yesterday to all of a sudden today being someone who a family member thought needed to come into your emergency department for evaluation. The last point that I'll make is something that I think is really important, in which when you talk with families and you get to see their pictures of these folks who, when they were much younger, you're reminded of their humanity, right? We sometimes think about people who show up in our emergency department as, yes, that older person sitting down there in gurney number 40 behind the curtain who's causing problems. But you want to remember that that is a person, and that person's trying to express something to you. They may not be able to express it to you in the moment exactly what it is, but with a little bit of Sherlock Holmes, you can sometimes figure it out. And ultimately, you need to remember that the cause of the agitation is going to drive your management strategy. So if you can figure out that it's pain that's causing somebody to act out and be agitated, then treat their pain. And there's some good data out there amongst people with dementia that prophylactically giving persons with dementia who are acting out Tylenol scheduled can actually be a good management strategy for helping with agitation. Is it delirium? Then treat the cause of the delirium. Is it just a progression of the dementia? In which case, I don't know necessarily that there's anything that needs to be done acutely there in the emergency department other than reassurance and connecting that person with resources for care outside of the department.
So a few myths around diagnosis of delirium. One of my favorites is delirium is like porn. I know it when I see it. Trust me, you don't. I don't. That orientation is a key component of the delirium assessment. It's actually a minor component of the delirium assessment. And that in the ED setting, it's really not possible to distinguish delirium superimposed on dementia or DSD. So in terms of the I know it when I see it, the reality is probably 20% of delirium you're recognizing. Some studies say 13%. Most of that's driven by chart reviews of whether you documented it. I went up and asked my colleagues, is this person delirious or not, after doing a delirium assessment. They were right about 33% of the time. They captured about 33%. There's one study that said we got it correct over 50% of the time, that we identified delirium over 50% of the time. But most of the studies are in that 15 to 20% realm. So probably missing delirium 80% of the time. I always thought that that was probably because we're missing the hypoactive delirium. Here we're focusing on agitation. I would be remiss if I didn't mention that hyperactive delirium is a minority of delirium. 10% of delirium you see in the emergency department is hyperactive. The majority is either mixed, where they'll fluctuate, although you may not see the fluctuations, or hypoactive. Hypoactive is that older individual who's been in your emergency department for 7 hours, has been sleeping, has not complained about being in your emergency department for 7 hours, has not asked for water, has not asked to go to the bathroom, and has not asked for food. Okay, so that's hypoactive. Here we're talking about hyperactive. So I always figured we're identifying the hyperactive delirium. But in a kind of small study that I looked at, we actually were as bad at identifying hyperactive delirium as we were of hypoactive delirium. So specificity of all elements, pretty good, but our sensitivity of detecting hyperactive delirium was actually 39%, basically on par with hypoactive delirium. So we are missing it, and we're even missing it in the agitated patient. So focusing on orientation. So how many times have you heard the patient's ANO times 1 at baseline per EMS, right? And so you say, I don't have to explore that any longer. You actually should explore that further. So this is the DSM-5 definition, which I won't bore you too much with, just a little bit. And orientation actually comes in towards the end in that cognition, right? So delirium is a disturbance in attention, awareness, which used to be level of consciousness, and cognition. And orientation is an element of cognition, but so are hallucinations, so is disorganized thought, language disturbances, acute memory deficit. So attention is really orientation is only a small element of the evaluation for delirium. And then the idea that you can't diagnose delirium superimposed on dementia, you can. My title is wrong up there, I apologize. Some of the things to really think about is really the attention component. So if you look down near the bottom of this table where it says attention, attention is impaired in delirium. It is preserved in dementia till end stage. In psychosis, it may be impaired, but you don't really have to worry about that because remember, less than 1% of patients, of older patients, have primary psychotic issues. So you can kind of ignore that final column for the most part. But attention is a key distinguishing element between delirium and dementia. Other things that are good distinguishing elements are level of consciousness. So for the hypoactive delirium, that can be common in delirium, not in dementia. We're talking about agitated delirium here, hyperactive delirium, but that's something to consider. Fluctuations and hallucinations. And hallucinations can be common in delirium, rare in dementia with the exception of Lewy body dementia. Lewy body dementia is kind of an exception to a lot of these rules, but again, for the most part, hallucinations should be absent in dementia till end stage. And this is Jin Han's delirium triage screen, right? So this you can use to assess for delirium in a patient with dementia. If it is DTS negative, they don't have delirium, right? So first you look at a level of arousal. How aroused are they? Are they hyper-aroused? Are they sedated? Do they have a normal level of arousal? And then you do a test of attention. Spell lunch backwards. Name the days of the week backwards. If they have a normal level of arousal and they've got attention preserved, they don't have delirium. So you have a patient with dementia who is ANO times 1 and at their baseline with preserved attention and a normal level of arousal. They don't have delirium. You're done. Pretty easy. If your DTS is positive, it doesn't mean they have delirium. It means you need to do an additional test. You have to do more evaluations. There are a number of different tests out there. A lot of them do a little worse in the patients with dementia. There's one called the 3D CAM, which hasn't yet been tested in the ED setting, but it actually has very good test characteristics in dementia, probably some of the best test characteristics in patients with dementia. So if you're interested, that's out there. And that's basically a set of questions that you ask and can answer. The challenge is all of these require, once you get past that screening stage of level of arousal and attention, you have to figure out, is it acute onset and is it fluctuating? And that requires collateral.
So we're going to talk a little bit about collateral here for a moment. One of the myths out here is that when we get a person in from the nursing home and we go to call them, is that nursing homes never pick up the phone. Is this a myth or is it reality? Well, I just want to, this is a few takeaway pearls. And I love telling emergency room doctors this because I'm actually one of the people who sends patients to the emergency room at 3 o'clock in the morning. And I actually try and be pretty thoughtful about who I send there and who I don't. There are actual doctors who are authorizing patient transfers to the emergency department. And I encourage you to try and reach out to them because it can be a great source of information as to the reason for the transfer and the background on the patient. I know it may be a few hours later before you actually get around to that patient, but chances are I've been awoken at 1 o'clock in the morning about that patient needing to go out to the emergency department, and I'll probably get a call back around 6:30 or so in the morning to tell me that the patient is back and that there are changes for orders. So I'm up already, right? And it takes me 2 hours to fall asleep after I've been woken up. And you know what? It's a night on call. That's what happens. Call me if you need that type of information. And sometimes I can fill in. I'm speaking for my folks from my field. We can fill in that type of information that nursing home nurses sometimes are not able to because they're traveling nurses, they don't know the patient, this is their first night on with them. Believe me, I've heard all of these reasons why. But give a call. Remember also that the doctors are increasingly, as well as the skilled nursing facilities, are increasingly becoming incentivized to look to try to decrease unnecessary transfers to the emergency departments. I've worked in a number of academic settings over the years. I'll tell you that this has been part of incentive bonuses that we get to control this as a quality of care marker. So understand that the person who picks up the other end of the phone may not be just, why are you calling me, right? They may actually want to hear from you about this because they thought that that person needed something by sending them there to the emergency room, and you may be able to help them in the long run take better care of them. So don't hesitate to call.
And then I'll send them right back to you. One of the often underappreciated causes of delirium is pain. And in older adults, this is one of the conditions that I've seen particularly either ignored or neglected just because we think that there's an active cause of it. And for those of us of a certain generations, we remember when we had a board question that said UTI was the answer, and so we stopped thinking about pain and we start looking for other things. So this is my plug for remembering to look for pain. One of the misconceptions is that if someone is delirious or demented, it's hard to get a sense of their pain scores. But fortunately now there are a lot of tools available on the web. We're going to talk about one of them that's most commonly used. This is the Pain AD scale. It's a pain assessment in advanced dementia. It was created for dementia, but it has been very useful also for patients with delirium. I won't go through every particular cell at this time. What I will tell you is the first time I used it, it took me a long time. By the third time, you kind of get used to it, and after a while, you develop this gestalt, and you know what to look for, and you have a very good sense of trying to get of determining what their pain level is. It all adds up to 10, and then it correlates roughly with our usual what's your pain 0 to 10. Although no one has done that study, so if one of you is interested, that's an opportunity right there. So use to validate pain scales such as Pain AD. Check also for constipation or urinary urgency because that's an underappreciated cause of pain. When you write for pain orders, take into account their cognitive status. I have often seen PRN orders, and there's someone there who really is not able to communicate because of their delirium. So our suggestion would be instead of PRN orders, just write standing orders. Yeah, they're in your ED for 4 to 8 hours if your ED is anything like my ED, our ED. So they'll be there long enough to get a couple of doses for this. I know some people out there like to use morphine, and just to remind you that morphine has an active metabolite, so it actually increases, paradoxically, delirium in some patients. So we recommend the use of Dilaudid. And if you're afraid to use Dilaudid, you can use 0.5 of Dilaudid, but in this day and age, you will find a surprising number of older adults who are actually quite resistant or not opioid naive, so don't be afraid to use higher doses. Why I like opioids? I can reverse it. I can't reverse antipsychotics as easily. So,
I think, does Northwestern start at 0.25 for Dilaudid?
We start, 0.2.
Then I showed up and I started 1. Sorry. Remember to start low. So low for me may be different than low for you. Right? All right. So I'm dating myself, but when I was a student and studying for a shelf exam, there was a question about this person comes in, they're confused, they're swinging at the nurses. What is the most important next step? And the answer is send them home with Bactrim, right? Because this is a UTI. This is traditionally what we've been taught. But remember that having a positive UA doesn't mean that they have a UTI. They may not be able to tell you that they have dysuria, but this is something where we have to be mindful of. So asymptomatic bacteriuria is very common. It does not equal an UTI. Now, sometimes we've heard the fact that, well, they can't tell you they have dysuria, but they're delirious. So that's the symptom. So treat them anyway. What we're telling you is don't do that. Try and resist to do that unless you get a really good history that they've been having all the symptoms related to a UTI or a fever if that's the case. So diagnostic anchoring in UTI, if you get anything out of today's lecture, is just remember the danger of potentially thinking that this is an infectious cause when there's something else in it. So.
And similarly,
Yep.
the number of times families who come in and say, well, will you check the urine because my mother never has symptoms of UTIs? You may have to educate that family member that perhaps in the past they've just had asymptomatic bacteriuria. It doesn't mean it's not the UTI, but you shouldn't stop searching because you've got a borderline urinalysis. Do not anchor on the urinalysis because you may miss actually a different precipitant of the delirium. So in terms of other workup, so we're only giving you a snapshot of this. You know, infectious causes are the number 1 cause of delirium. Acute neurologic causes are number 2 in the ED studies. But there are any numbers of causes that relate to changes in homeostasis for the individual. One of the misconceptions, given that acute neurologic causes are common as a precipitant of delirium, is that a head CT should be routinely obtained, and that the patient can't be admitted to the medicine service for delirium without a head CT. And the reality is, of people who get head CTs, so when you look at a group of people who got head CTs for delirium, generally about 80% of the delirious older patients, 15% are positive. So it's not a lot, okay? And if you've got an agitated delirious patient and you're sedating them or restraining them for a head CT, there's some harm from that. 3 different studies have looked at predictors for an abnormal head CT, and all 3 have said that these are, well, 2 of them have said 2 of them, and the other came up with the 3, but they all sort of said we can capture between 90 and 95% of all abnormal head CTs with these factors. Acute focal neurologic abnormality. It may be challenging, but you need to do a neurologic examination on your patients with delirium. They may have a stroke, they may have an intracranial hemorrhage, but you do need to do a focal neurologic exam. So not delirium, but another acute focal neurologic abnormality. Odds ratio of 18 for an abnormal head CT. Impaired consciousness, so a significantly decreased level of arousal, really somnolent, hard to arouse. Odds ratio of 5, and a recent history of fall. You might add into that like anticoagulation, univariate analysis in one study, anticoagulation carried a signal, in multivariate it fell out. So I generally say acute focal neurologic abnormality, impaired consciousness, fall, consider blood thinners, but 90 to 95% of abnormal scans can be caught with those 3 factors. And if you go down the route of doing head CTs in everyone, you may be medicating or restraining people unnecessarily. That may worsen their delirium. Another potential pitfall is if you do really need to get a head CT, someone is extremely agitated, has a fall, has evidence of head trauma, and goals of care might be that they want something done about it. One of the pitfalls we see is someone giving someone an antipsychotic, not getting adequate sedation, giving another dose of the antipsychotic, not getting adequate sedation, and then giving a sedative, and stacking all of these medications. So if truly you need that head CT, and they're really agitated, then consider starting with a sedative. It's one of the rare instances when we do recommend sedatives instead of antipsychotics as first go. If you really need it as part of your diagnostic evaluation, a common pitfall is stacking antipsychotics, not getting adequate sedation, and then throwing on a benzo on top of that, and then that patient is snowed for hours, if not days.
So we're going to talk a little bit here about agitation management. And one of the pitfalls that you can find yourself falling into is relying on medications as the first line modality. A second one that you can run into is thinking that, well, the patient's disoriented. What I need to do with them is really actively reorient them. And that sometimes, that I've heard many times in many talks given over the years. You need to pay attention to employing these non-pharmacologic modalities. Having the family at the bedside is a really cheap and easy one if you can get them there. Ensuring the person's comfort, having soft mattresses, keeping them warm, providing them with hydration. Avoid restraints, so limit tethers, IV tubing, telemetry, BP cuffs, catheters. We call the Foley catheter in geriatrics the one-point restraint, right? So avoid doing that unless you honestly need it. Promote mobility unless it's clinically contraindicated. So if people can get up to use the bathroom and you can provide enough supervision for them to do it, try to do that. This is what I call trying to hit the normal button on the computer for that older adult. Keep them as normal as possible. Preserve their perception, orientation, and participation. Ensure that they can hear you, so use pocket talkers if you need to. Address the hearing impairment. Make sure that they can see what's actually going on. One of my favorite stories, it wasn't somebody in the emergency department, somebody up on the floor in the hospital I was called to do a consultation on, of an older gentleman who they said was demented, and they wanted me to do an ACE consultation with him. I came up there. It was an older gentleman, yes. Yes, he wasn't able to answer my questions, but when I dug deeper, he was from Somalia, spoke a Somali dialect, and was also deaf, right? And when I got a translator and I got a pocket talker on him, he was remarkably intact and knew all of the things that were going around him. His dementia was solved like that. So that's the one time when I could go ahead and solve dementia, right?
Is there a billing code for that?
You can see that there are educational resources here that if you want to go home and look for these, you can. The Niche program is a wonderful program that's out there. Remember the Hartford Institute for Geriatric Nursing is out there. Geriatric Care Online, and AGS has a toolkit for non-pharmacologic modalities. What we have there on the right is a delirium toolbox that has been put together and that some centers use for trying to calm agitated patients. And you can certainly read about these things online. I want to point to the work of Joe Flaherty here from St. Louis, who has come up with the TADA approach for managing agitated patients. And in his case, he was applying it to persons with delirium. So TADA, it's pretty simple here. The T is for tolerate. Tolerate behaviors that are challenging but not dangerous. Anticipate the needs of patients who are unable to communicate their needs. And don't agitate patients who are cognitively incapable of processing what you're trying to do to them. So if somebody is not able to understand that what you're trying to do is change their adult diaper, and it doesn't have to be done immediately, and they're already agitated, and you already know from your past interactions with them that they're already on edge, just because it says on your watch that it's time to change it doesn't mean that it has to be done right at that moment. That person may be able to sit and calm down another half hour and have it be done for them when they're much calmer. I mean, this is a sort of one example of don't agitate patients. The other piece that I point with this too is just orientation, right? We say that, reorient your patients all the time. Make sure that they can go ahead and see the clock in the room. They say to you, oh, I think it's Sunday. You say, no, it's actually Tuesday. Remember that constant reorientation of people who are on the borderline agitated could drive them over the edge and create more of a problem for you. Sometimes it's much just better, as long as it's not a dangerous thing that they're talking about or they're trying to do, to just go along with it. Go along with the flow.
One of the dementia caregivers that works at my institution likes to say, please don't try and actively reorient someone who's really disoriented. Reassurance is really important. Distraction is another modality you can use instead of active reorientation. So when you're looking through all the delirium literature where all of us physicians have said reorientation is key, if they're agitated and they're disoriented, maybe it's really reassurance and distraction, and it may be that the family member, the skilled nursing facility, can give you some tips on how to distract them and how to calm them down rather than this active reorientation.
Persons with cognitive impairment, right, show a diminished capacity to adapt to a new environment around them. And so since they can adapt to things, we have to adapt to them. It's changing the paradigm that you're looking at your interaction with them. Go on to hallucinations here. A common misconception around hallucinations is that these should be treated with antipsychotic medications. And have a few pearls for you here, is that hallucinations in person with dementia are in fact pretty common, particularly in the later stages of the disease. One of the key things that you should do before deciding how you're going to treat these is you have to assess whether the hallucinations are distressing or in some cases, in fact, culturally appropriate. I'll tell you an example of this. So I work in a dementia care clinic, and a gentleman who I diagnosed with early stage cognitive problems came in and told me that yes, he in fact does see things that other people don't see, and yes, he does in fact hear things that other people don't hear. Well, this gentleman was an American Indian from a reservation who had come in 3 hours to see me, and he said to me right after, he said, yes, I do talk with my ancestors, and that's appropriate for me, so don't think I'm going crazy on you. So you have to go ahead and interpret with the story. That's a case where I would say, yes, he is having these, but it's appropriate for him. In persons with dementia, you should remember that if you're going to work up somebody for their hallucinations, you want to perform a medical evaluation that's consistent with the goals of care and the stage of their disease. So if somebody's really end stage with dementia, and there's not a lot that's probably going to be changed in their management by going and sedating them and putting them into a CT scanner or an MRI machine to look for metastasis, then why do the test at that point? And talk with families. Most families already know when they get to that stage of disease that things are advanced, that their goals may be need to be changed over time. Don't be afraid to initiate that conversation if you're the person on watch and nobody else has had that conversation with them then to that point.
And I was telling this group earlier that I recently was very proud of myself because a patient had been sent in for a geri-psych evaluation after being treated for delirium with 2 rounds of antibiotics for a UTI because of persistent visual hallucinations. And I went in and I did a full assessment for delirium. She screened out by the DTS, but I did more. And I went in and I thought about, is there any possibility she's got Lewy body dementia? And I explored with her and her family her cognitive status, and she was actually quite bright, but she had vision loss. It was Charles-Bonnet syndrome. I was confident she wasn't delirious. I was confident that she didn't have a primary dementia. I was confident she wasn't one of that 1% with a new onset and a psychotic disorder. Remember, it's visual hallucinations, not auditory, which are less common in psychiatric conditions. So there are some medical conditions that present just with hallucinations.
So now we're turning our attention to those instances where you have to use pharmacologic modalities or an intervention. So this slide will talk about the dangers of the things we commonly do, and then the next slide we'll talk about some recommendations. So remember, sedatives, benzodiazepines especially, they tend to be overused, and I think many of you have heard that in patients with delirium, they tend to paradoxically worsen the delirium. That is particularly true for people with hyperactive delirium. There are, however, instances where we might want to use them. And one instance is, as my colleague said, if you have a trauma patient, you really need to get them calm for the CT scanner. And you do that because potentially there's something life-threatening, and then you deal with the worsening delirium after the fact. The second instance is that there are surprisingly a lot of older adults out there whose primary care providers put them on regular benzodiazepines for the nerves. So people who take 2 of Ativan at night, 5 of Ativan at night, and then now they hear they're delirious, so then you change your differential to think, is this benzodiazepine withdrawal? Those are the people for whom benzodiazepines, IM or IV, would be appropriate. Antipsychotics. How many of you work at places that have 5 and 2 or B52s? Okay. Anybody here work at a place that has 5, 2, and 1? Okay. Anybody know what the 1 is? I won't name my former shop, but it's 5 of Haldol, 2 of Ativan, 1 of Cogentin, routinely, right? So we do that reflexively because I think we know places that do that. It's almost cultural. But you know, the fact is there's not a lot of good data there. The one thing that the literature shows that is no one has ever died of 2 milligrams of Haldol. We almost never give 2 milligrams. The other thing is, if you put all the data together, there really isn't a consistent message there that this works reliably. What we do know is that it often converts hyperactive delirium to hypoactive delirium, and that has a high mortality. We also have heard anecdotally at many places that we don't give these medications enough time to take effect. And so as my colleague has mentioned, we stack them. We give 5, we wait 5 minutes. Boy, she's still throwing stuff. Let's give another 5. And then, oh, she just said the F word. Let's give another 5. Next thing you know, there's 15 milligrams of Haldol within 10 minutes. And it said, she's not doing anything now. So that's where you have a different set of a problem. And the last thing is, I have heard this actually here at SAEM talking to colleagues anecdotally, but there have been, to my knowledge now, 6 instances across 5 different institutions where Haldol was given to a patient who had Parkinson's disease and it ended up in a death. Does anyone here, has anyone else here heard of that? So I don't know the true mechanism. Gentleman from Canada. Okay, so it's an international phenomenon, right? So just be careful. So what I've told my residents and colleagues now, if you hear Parkinson's, don't get Haldol. Get something else. Don't get Haldol, okay? So let's talk a little bit about, can you advance the slide? Thanks. Couple of pearls. These are words of wisdom handed down to me, and I'd like to share with you all. Start low and go slow. You can always give, see what happens, give again. And I am sensitive to the fact that there are times when we have to get control of the situation, and those are special circumstances. But as much as you can allow for it, start with low doses and be patient. And again, one-time orders, let them come to you and tell you, hey, I need more medication, so you can reassess the patient. Don't do PRNs. And benzodiazepines. Overuse in delirium, underuse in people who take benzos regularly, and sometimes underuse in really high-pressure, intense emergency situations. If you get a patient who has known dementia, and this is a progression of their disease, so they're not delirious, they're just advanced in their dementia. So this is where you can actually think about medications that have been proven to work, and that is Haldol, risperidone, and or trazodone. Okay? But usually you will have some clue to that. Hey, this is someone, my mother takes a risperidone every night, trazodone every night. They came into the waiting room at 11 a.m. Now they finally get to their bed at 7 p.m. and it's sundowning time. So make sure they get those medications. Okay? And the last thing is a plug for pain. Remember to think of pain first. We won't really give you a recommended algorithm because I think we all practice differently and we want to respect, the vast experience that everyone here has. But I tend to prefer treating pain or presumptively thinking that this is pain, again, because I can reverse it. So I would go opioid, 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 opioid. They stop breathing, a little Narcan, more opioid, and then I'll think of something else, like an antipsychotic. So,
if you don't think they have pain, then
if they don't have pain, then don't.
Then don't. There was during lightning, unless you're ordering it for yourself, I don't know. There was a lightning oral yesterday where someone looked at delirium, pain, and IV opioid administration, and at least in that small study, preliminary data did not show a signal of delirium with opioid administration. There was a signal of delirium with pain. So we don't have a huge amount of data out there about whether opioids truly are contributing to delirium. I think it's more likely that we are under-treating pain, and pain definitely is associated with delirium, than giving opioids and precipitating delirium. So delirium prevention. So this is sort of one of the things that I try and teach is that delirium prevention is not simply in the purview of the inpatient care teams. It is something we should be thinking about in the emergency department. And I think a lot of people think about that as really being an inpatient issue. Truly, that most of the research and work on this has been in the inpatient setting, but I think it's time for the emergency medicine to take hold of this concept. Another misconception is that delirium is inevitable in older adults. They're going to get delirium. There's nothing we can do about it. Either they get it or they don't. We can't reverse it or prevent it. The reality is, so the ED environment and some clinical things that you do may be deliriogenic. So the environment, absolutely, probably one of the most deliriogenic environments for a patient in the hospital setting. Perhaps the OR might be a little bit more, but probably we're number 2. And some things that you do, Foley catheters, medications that you give, may provoke delirium as well. Factuality, delirium is preventable. So if you think about it from the emergency department data, 7 to 10% of our patients, somewhere around there, have delirium. Up on the inpatient unit, this is a study from Italy that did a delirium day, like across 100 institutions. 20 to 25% of older patients on the inpatient units had delirium on that one day. So about 10 to 15% of people are getting delirium after we admit them. Some of that's progression of disease. Some of that might be because of what we've done to them. I think that's something we need to keep in mind. The other thing is we think about infection and acute neurologic disorder as a precipitance of delirium in the ED, but if you look at inpatient literature, medication is a very common and sometimes the number 1 cause of delirium. Is that because of medications they were on? Is that because of medications we gave them? I can't tease that out for you, but we should be cognizant of the medications we're giving patients and that we're not giving things that will precipitate delirium. In terms of the ED as deliriogenic, so one small study that looked at lengths of stay greater than 12 hours and did some adjustments for comorbidities and age, and a longer length of stay increased the likelihood of development of delirium after admission by 2-fold. So people being admitted not delirious in the ED, if they had length of stay greater than 12 hours, 2-fold increase in delirium. If you think about things that you can modify that are delirium precipitants, right? You can't modify the fact that they come in with an intracranial hemorrhage. You can modify the medications you give them. You can modify your approach to physical restraints and tethers. You can modify their pain. And then if you think about the environment, so what are the insults that cause delirium? So it's bright lights in the middle of the night. It's constant noise. It's sleep interruption. That's the ED, okay? And then immobility. So delirium prevention modalities predominantly are non-pharmacologic. The pharmacologic ones to date have been unsuccessful on the inpatient units. And a really good meta-analysis looked at these non-pharmacologic approaches, 30% reduction in delirium, right? So delirium is deadly. We know that, even when you control for comorbidities. A non-pharmacologic approach to delirium prevention decreases delirium by 30%. And what are those approaches? Don't give bad medications. Something we could think about doing. Sensory enhancement. So encouraging the family to leave hearing aids, or doing what they do at Northwestern and at Mount Sinai and having auxiliary hearing aids available. Encouraging them to keep their glasses so that they can see what's going on. Reorientation, maybe. Reassurance, redirection, distraction, yes. Pain control is a component of those. Making sure that they're eating and drinking as long as they're not pre-op. Making sure that they get to go to the bathroom and they get to avoid. Those are all things we could actually do in the ED. And if your patient is boarding for a prolonged period of time, please think about that. Think about normalizing their activities, hitting that normal button, as Mike said. But also think about, if they've been boarding in your ED for a prolonged period of time, advocating for that person to get out of your ED to an inpatient unit. And why should you care about preventing delirium? Well, it is deadly, okay? So 6-month mortality, about 37% versus 14% for geriatric patients without delirium. If you adjust for comorbidities, diagnoses, delirium still carries a signal. So delirium in and of itself, we think, is deadly. And we think as a myth that delirium is fully reversible, like that's what you learn in medical school. Dementia is progressive and delirium is reversible. The reality is a hit of delirium actually alters your cognitive trajectory. So whether you have baseline dementia or no baseline dementia, your cognitive status will decline faster if you get a hit of delirium. So delirium prevention, purview of the ED, think about it. Advocate for your patients getting to bed if they do need to be admitted. Avoid things that can precipitate delirium, because you may save someone's life and because you may improve their outcomes, including their cognitive status.
So we'll talk next about disposition. There's sort of a myth out there, and I don't know if it's a myth or just a sort of common thought out there, that all delirious patients need to be admitted. We're very keen on talking about in the delirium field about the fact that delirium needs to be thought about like a heart attack for the brain, right? That the mortality rates are similar, that this is a brain emergency and people need to be admitted upstairs into the house. I don't know that we're actually sure that admitting people to the hospital, considering all the data that we've just talked about the hospital being a deliriogenic environment in and of itself. I don't know that it's clear that admitting people to the hospital for a diagnosis of delirium is actually going to improve their outcomes. Hospitals, as we know, carry risks beyond delirium. There's risk of nosocomial infections. There's risks of iatrogenic things that we do to our patients. We keep them immobile. We know that people suffer functional decline after hospitalizations, and they experience what most older adults fear the most, which is loss of independence. If you talk with any older adult, that's what they'll tell you what they want. They want to stay as independent for as long as possible. Nursing homes, on the other hand, depending on your local environment, may be able to provide quite complex care. So if you have a person with dementia who you determine is delirious, it's worth, I believe, having a conversation both with the person, if you can have the conversation with the person, with their family, and with the providers back at the nursing home about whether or not they can handle what needs to be done for that person in that environment. And with careful care coordination and support at home, it may even be feasible to discharge a person to home if the family is really well prepped and understands what's going on. Again, these things haven't been tested, but it's possible for you to use clinical judgment if you get the stars to align here to imagine a disposition for a person other than needing to go upstairs in the hospital. But that depends upon picking up the phone and calling and understanding what it was that they were sent in there for, what the person who sent them in there for was looking for. So it requires some communication.
So we're happy to take questions, but we're also happy to open the floor to what you guys do and to hear what you've done successfully to manage the agitated older person at your facility. I know there are a number of people here who have geriatric EDs or who have worked on these geriatric principles, and if they have pearls and strategies that they have that they want to share, we're happy to have you share as well. So happy to take questions and happy to hear your thoughts and experiences.
There's a mic up front. We also have mobile mics if you'd rather.
I just wanted to share a geriatric life hack that I learned. If you don't have an ED that has the audio enhancement devices or pocket talkers, just take one of the disposable stethoscopes for infection control, like 50-cent stethoscopes, put the earbuds on the patient and speak into the wall, and it works amazingly.
The other one that I've had an audiologist tell me about is that that the iPhones, that there's actually an app that you can find for your patients that will go ahead and, if you put in earbuds into the phone, put those in their ear, that it actually can be like a microphone for them too, which is useful because I find that sometimes my patients don't want to spend the $5,000 that it costs to get a hearing aid, right?
So great presentation, thank you. Can you role play the conversation back to the nursing home about wanting to send someone back? Because it seems that whenever even if you've done the workup and you can't find anything, their usual response from the nursing home is, well, we can't take it, and that's what we sent them to you. So what would you put into the conversation to convince this nursing home that it's okay to send this patient back? Because they seem to be very hesitant.
So it's going to depend, obviously, upon your relationship with those doctors who are on call for that nursing facility. But so I've certainly gotten the call back of, hey, Dr. LaMantia, it's Dr. Jones. I'm down here in the emergency department. We took a look at Mrs. Peabody, who you sent over a few hours ago. We gathered from the note that you wrote in the chart that you were concerned about a possible urinary tract infection, but you couldn't get labs back. She was a little hyponatremic the other day. You weren't really sure about this. We've looked her over head to toe. We sent her, unfortunately it happens, like through the CT scanner. We sent off the labs. Everything's coming back normal, and we can't make heads or tails of her, and she's sitting here comfortably. I can't really justify an admission for this person because I have nothing to admit her for. Is there something else that you wanted me to do for her? Because otherwise I think that she's ready to go back. And that's the type of, that shows me that I've had an emergency department doctor who has looked at my chart note, has figured out, because I always, maybe I'm the rare guy out there, but I'm always going into my EHR in the middle of the night, going and writing a little telephone note in my Epic chart about why it was, because I got to document it for the docs the next day to know that that their patient was called on. And it shows me that you've listened to what my concerns were, that you did a reasonable workup for it, and you covered what, in my brain as an internist, I was worried about, that the patient potentially had become more hyponatremic or had a UTI.
But also, I think I share Dr. Char's concern because it is very regional. It also varies place to place. We've all worked at the ED where you get the nursing home dump, and there is almost no information from a physician. It's just a nurse writing, patient threw something at someone, and then here you go. And the meds, maybe you get the med list, maybe you don't. And we're sensitive to that. But I think what Mike is talking about is if you know your community, and he works up in Vermont, Burlington, that actually has a very good network with nursing homes, these things can happen. So wherever you are, if you have that network, or you can somehow, it takes a little bit of investment to build that network, and you find out that there are 3 doctors that do med control for the nursing homes, it's worth to talk to those 3 doctors, say, hey, if you send someone to our ED, we'll take them, but in exchange, we want to know how to get hold of you so we can send them back if we need to.
But the key is talking to the right person at the facility. So if you're talking to the person who is one of two nurses on that floor at 3 a.m., that's probably not the person you should be talking to. There's usually a supervising nurse that's available as well as a supervising physician, and trying to get on the conversation with that individual. I think one of the things that I take away from it is understanding that if I hospitalize that patient, I may make it worse, right? Change of environment is much worse. Immobility happens in the hospital setting. We do not ambulate, we do not normalize function for our geriatric patients. So hospitalizing them, even if they have a little bit of delirium due to a very treatable source on an outpatient basis, may be the worst thing for it, but it may be that you need to move that conversation up to a different person, not the person who's overstretched at night at 3 o'clock in the morning, but the managerial person or the physician. It may be that you keep that person until 7 in the morning when they have the daytime staff come along and coordinate that person back at arrival, but just keep that person in your ED for a few more hours. But I would always advocate for the potential worsening of it by keeping them in your ED or admitting them to the hospital as one of the reasons to potentially send them back.
Great discussion. Thank you very much. Could each of you tell us, when you have a patient who's agitated, they're not in pain, they're agitated, you try to calm them down, you got them in a quiet spot, their heart rate is up from agitation, you're concerned about their well-being. Can each of you give me your go-to drug that you give them so they can learn to calm them down in ED?
So if they have dementia, I give them their home meds if they haven't had it yet, or they're scheduled. That's number one. If they don't have dementia, I really try and exhaust my search as to whether or not there might be a cause of pain. And this is where I think we may vary. So my first go-to are opioids, fentanyl or Dilaudid. And the reason I do that is because I've just seen too many bad things with antipsychotics. I also know that antipsychotics tend to work long, and the response is very variable. I have seen hyperactive become hypoactive, because sometimes the pain just calms them down a bit, and then it allows them to reset and adjust to their environment. It gives me just enough time if I need to do something like get an IV or give them some treatment, some medication, look at their wounds. But if they are delirious and I don't really need to do anything active, and for example, they have a pneumonia, and I've got that from some other source, or they'll sit still for an x-ray, and it's just a matter of bringing them either into the hospital or transitioning their care out, I will sometimes leave it alone if it is not too excessive. So if they're muttering, if they're just active a little bit, because sometimes I learned that doing less allows them to calm them down more if I'm afforded that. So, but to answer your question, my go-to is to use narcotics first, because I've seen that successful. I can always reverse it if I have to. And then my second line would be antipsychotics, but by then I'll get an EKG, make sure their QT isn't prolonged, so I feel more comfortable using Haldol, for example.
I'll say I can reflect. I don't work in an emergency department, but I get phone calls all the time from families who have persons with dementia at home, and they have behaviors that are bothersome to them. My first line drugs tends to be trazodone. I tend to use that, tend to figure out when during the day the person has agitation that pops up and give it to them a little bit prophylactically before that. If I've exhausted trazodone, I then will frequently go to Risperdal. I think that the way that I approach use of antipsychotic medicines, as well as my approach to using opioid medicines, is it really comes down to getting comfortable with a set regimen of drugs, knowing what the side effects are of them, knowing how to administer them, and what to look for to know that you've gotten a good response.
So I agree that Risperdal and Haldol might be an appropriate choice. If you look at, and then if it's nighttime and they're really awake and you want a little bit of a sedative effect, then I think Seroquel and olanzapine have a little bit more sedative effect there. First and foremost, if it's mild agitation, no medications, and that's what the specialty societies would recommend because of the risk profile of drugs. It's really for moderate to severe agitation, and particularly where you're concerned of the patient being a risk to themselves or to others, where medications should come into play. And then thinking about PO versus IM versus IV, what's the right approach to do with that, and then making sure you give an appropriate time for effect. So PO will take a lot longer to hit peak effect. IM can be anywhere from 15 to 40 minutes to hit peak effect, so do not stack those drugs. I did see one small study that sounded amazing, where they had family members dictate a message on like an iPad, and when their family member was starting to get agitated in the hospital, they actually played that message, and it calmed the agitation, and the patients were able to be redirected that way. So if it's not severe, can you get a family member on the phone? Can you get an iPad and actually have a family member do FaceTime or something along those lines? And I think there are busy vests in some of our hospitals that can keep patients active and redirect their agitation to something to pick at instead, or a stress ball or something like that for a non-medical approach.
I'm forced to think of one anecdote from last week in clinic. Was someone who, the family was in fact downplaying how much the agitation was happening in the evening. And this is somebody who really very easily could have shown up in the emergency department. But we had a good relationship and they waited to see me. They said, you know, in fact, the mother every evening would call them. And I said, well, how often is she calling? She says, 20 to 25 times a night. Like she hangs up the phone and she calls up like 2 minutes later and wants to talk with me. And it's just driving us nuts. We had tried pharmacologic therapy for managing some of the agitation earlier in the day. We just extended a little bit further, but at the same time we talked about non-pharmacologic therapy. We figured out that this woman loved Elvis, and in fact I took out my iPhone and put on Elvis #1 hits in the office, and she like completely got into it. And we figured out that she also likes pictures. And so the family talked about putting together a picture album for her to sort of do reminiscence therapy in the evening. And they were talking about getting a sitter into the home too to help decompress, what her husband, who was like 85 years old, needed to do in the evening. So multimodalities at once.
Sorry, just a quick addition to the comment earlier. If you give IM Haldol, it may take a while to kick in. You give IV Haldol, that's when you have a lot of problems. If your hospital allows it, consider sub-Q Haldol. It's done in infrequent places. I was taught that by a geriatrician. You probably will have to talk to whoever the head pharmacologist is to get permission, but sub-Q will deliver a small dose quite effectively, so that's an option.
Last question? If you have the... Oh, absolutely.
Thank you. My name's Allison Hayward. I'm from Brown. I'm really interested in the non-pharmacologic methods for these patients, and as you know, working in the ED, a lot of times people just go from like, okay, you're in the hospital, you're all right, and if that doesn't work, like, let's do Haldol. And so I'm just wondering, I haven't found much research that's been done on other kinds of things that could be used for these patients. I mean, for kids in a pediatric ED, they've got child life, they've got all kinds of things for distractions that, you were mentioning, and I noticed in that delirium toolbox that there were other things aside from just hearing aids and so forth that they maybe try to use to distract the patient, and you were just mentioning some of them, but I quickly looked and didn't see any research on the delirium toolbox, and I was just wondering what people are using.
The Delirium Toolbox comes out of the VA literature, so if you look there, one of the VA researchers from Boston, I think, started the Delirium Toolbox idea. But shout out to Mount Sinai.
Jim Rudolph, who I think is now at Brown,
he
actually may be someone to reach out to at your home institution about this.
Okay. And then Mount Sinai and Northwestern have a couple things that go on, including a volunteer program where they train volunteers to specifically work with the geriatric patients. And they have on them hearing aids, stress balls, visual aids, Sudokus. I think some people carry busy vests, which you put on and have all these little things that you can twiddle with, so that agitated patient that's picking can pick at something instead of the IV. Is there a randomized control study of any of those? No. And then the other thing that I would say, which is really important, and some skilled nursing facilities are starting to do this as part of their transfer of patients with known dementia, is what are the tools that calm that patient? So if it's a patient coming from a skilled nursing facility, pick up the phone, call, and find out what are the things that are calming for that patient. And if there's a family member with that patient, asking the same question and then asking the family member to stay.
Or sometimes they just want to talk to somebody. The nurses obviously can't, so that's where an overeager medical student or the off-service intern would be a good choice.
And I think I'll let Sue get the last comment.